germline genetic testing. And the reason for that is we know that these DNA break repair genes are associated with prostate cancer lethality. They tend to have more severe cancers when they're diagnosed, and they have tried, it takes 10 years for 20% of the men to reclassify to unfavorable intermediate risk disease. Whereas if you have a BRCA2 mutation, at 2 years, already 20% has reclassified to unfavorable intermediate risk disease. So screening of these men will identify a minority with a mutation, but it's a minority that's important to know about because they manage as their treatment decision to go on surveillance or not. That's a little bit about the genetics of localized prostate cancer. But say that it's a man, and it can affect how it can affect surveillance. But say it's a gentleman who's thinking about treatment of their localized disease. Someone, for example, with low risk, favorable intermediate, or even intermediate risk disease. How do they think about, do they need treatment or not? You can also look at their genomics. The genomics I'm going to define for this talk is what's happening with their RNA expression levels. So not what's happening in the DNA, but how much certain genes are upregulated or being overexpressed. And there's 3 commercial tests available to look at that. There's a Polaris cell cycle progression score, which looks at genes that are involved in cell division. Oncotype DX prostate, that looks at genes involved in cell proliferation again, but also organization and androgen signaling. And then there's a Decipher test that looks at genes that are related to metastasis. And all of them give independent information beyond the pathologic Gleason score, beyond the stage, beyond the PSA. And what you see when you look at those genes is you can say, what does the expression of these genes look like? And do higher expression levels tell me that maybe I should not surveillance? And what you find is that about 7%, this is a complicated graph, but the yellow bars are low-risk patients that are on surveillance, and the blue ones are gentlemen that had disease, that had bad pathologic features at prostatectomy. What you can see is that most of the yellow bars are down here where the scores, genomic scores for bad cancers are in the blue, which is good. But as you get up here where the genomic scores or expression levels of cancers seem to be driving cell proliferation, division, metastasis, as these scores are high, most of this is the blue cancers, which you'd expect, the bad-looking cancers, but 7% are these yellow lines of cancers that should otherwise be followed. Same thing is true if you look beyond this detailed analysis at things like the GPS score, which is from Oncotype DX prostate, or the Polaris and CPP score, is that 7 to 8% of otherwise favorable disease that you would follow has genomic signatures of unfavorable disease and probably should be steered towards treatment. Conversely, for some of the patients that have favorable intermediate risk disease or high volume low grade disease that you're thinking maybe you should do treatment, but you're not sure if it's over treatment, low genomic scores with the Polaris or Oncotype DX prostate or Genome DX Decipher can tell you that you might be safe to not treat them. So this is with low cell cycle progression scores, no prostate cancer mortality at 10 years of follow-up in conservatively managed patients. This is low GPS scores showing a very minor amount of upgrading among the majority of patients with a low score. And so as a clinician, you can start to look at a paradigm for surveillance versus treatment for men with low risk or favorable intermediate risk, as if their genomic score is low, maybe that they can do surveillance. If it's high, they should go towards treatment. Average, maybe safe for active surveillance as well. And that's based on gene expression. How about the gentlemen that are going to get treatment for intermediate risk disease, like unfavorable intermediate risk disease? Here again, by and large, we will tell these people to have either surgery or radiation. Surgery is a removal therapy. It's mechanical. If the cancer lives where it is, it just is removed and it's gone. Radiation is a biological treatment, so it gets targeted to the cancer by image guidance, but it also depends on, is the cancer sensitive to that radiation? And there are clinical trials that show that for intermediate risk prostate cancer, coupling the radiation to about 6 months of chemical castration or androgen deprivation makes the radiation work more effectively, improve outcomes in those men. What those trials also show us is that a large proportion of men are over-treated by getting And so the question is, who needs that hormonal therapy and who does not? And it's somewhat hard to predict that by looking at their Gleason scores and their PSAs. So genomic tests might help. This is a series of men that were treated, had intermediate-risk disease prostate cancer, were treated by radiation without hormonal therapy. And what you see is in the blue line, their failure from metastasis was 100%. But in the yellow and the red line, by about 10 years, there was about 20% of people having metastatic events after their definitive radiation for their prostate cancer. What's the difference between the blue line and the yellow and red line is that the blue line had a low genomic decipher score, and the yellow and red had a high or intermediate genomic decipher score. So this has to be further validated by more data. They're looking at this in a larger clinical trial currently. But what this might tell you as a patient is, if I have low genomic score in intermediate risk disease, I might be able to have great outcomes with radiation alone. Whereas if I have a intermediate or high genomic score in intermediate risk disease, all the more reason for me to combine that with hormonal therapy. And the side effects of that short course of hormonal therapy, including sexual, cardiovascular, and metabolic side effects, are maybe perhaps worth it in that scenario.
How are you defining the intermediate?
So these patients were unfavorable intermediate risk by and large, which means Gleason 4-3-7 or multiple intermediate risk factors. There are a few, on the converse side, when I use this test in this way, if you're favorable intermediate risk, which is 3 + 4 = 7, PSA under 10, I can't feel it. If your genomic score is on the high end, meaning like it's in the high risk category, I tell those patients that I think they should get the short course of hormonal therapy with their radiation. For low risk patients like Gleason 3 + 3 = 6, it doesn't matter what their genomic score is, I'm not going to give hormonal therapy with the radiation. There was a clinical trial that actually tested for the oncologic benefits of giving the 6 months of hormonal therapy, and did show the benefit. And right now, the same company, as you can see, this is only with about 100 patients or so, but the same company is looking at that large clinical trial and taking the tumors from that trial, analyzing them by their this genomic assay, and trying to figure out, does this bear out in a prospectively controlled randomized trial? So how about after radical prostatectomy? How can we use decision making there? Again, the genomics is going to give us gene expression data that will tell us things about prognostic risks. After radical prostatectomy, about half the men are going to have what's called adverse pathologic features. That includes people who have positive margins or have T3 disease, which means they had some extra prostatic extension or seminal vesicle invasion at the time of prostatectomy. These patients are at elevated risk for cancer recurrence, and has been shown in multiple randomized trials that by giving them radiation after surgery, they can improve their oncologic outcomes. Less recurrence of disease, less distant metastasis. What was also shown in those trials was that when you use that strategy, you may be over-treating with radiation up to 90% of the men. So most of the men are being treated unnecessarily to see benefit in 1 out of 10 men. There's 2 studies that have recently been reported, not published yet, Radicals and Raves, that look at that even further and kind of substantiate that idea that most of the men are getting over-treatment if they're getting what's called adjuvant radiation, like when the PSA is undetectable. So what can we do to see if we can modulate this? So instead of saying everybody with adverse pathologic features needs treatment, let's make it so we can select out which men are most going to benefit. The number needed to treat isn't 10 anymore, maybe it's closer to 3. So again, because genomics gives us independent information, we can use that in this setting. This is data from a large retrospective cohort using the Decipher test. They get a genomic classifier score. And what they found is they took men with adverse pathologic features, those that had less than 2 risk factors, the risk factors being seminal vesicle involvement or the local invasion, Gleason scores of grade group 4 to 5, which is sums of 8 to 10, lymph node positivity, or a genomic score greater than 0.6, which is a high risk score. If you had only one of those features and you got adjuvant in the blue or early salvage in the red, you did equally as well. If you had 2 or more of those features, however, and you get adjuvant radiation, you did much better than waiting till your PSA was higher and getting salvage radiation. And these guys getting adjuvant radiation did almost as well as the patients who had less than 2 risk factors. So again, here if you use the genomics as a way to identify which patients you should treat versus not, your number needed to treat goes down from 10 to about a number needed to treat of 3.
What was the PLN?
Say again?
What's the PLN?
Oh,
Risk factor?
that is a pathologic lymph node positivity. So sorry about that. So that's if most of the guys going to surgery, clinically you think that they're lymph node negative because you did an MRI or CT and it's in children's lymph nodes. But sometimes microscopically at the pathology you'll see positivity there. And so to expand on this a little bit again, the previous trials were looking at adjuvant versus salvage radiation. Radicals and raves, which haven't reported, they've been presented at meetings, but they haven't reported out, look at the idea of early salvage radiation. So when the PSA after surgery comes to about 0.2 versus adjuvant radiation, so really PSA is less than 0.2. And they showed kind of what this suggested, which was by and large, if you had only 1 risk factor, you did not benefit from the adjuvant radiation. That most people should get early salvage. But this also substantiates how to identify who needs that adjuvant radiation. It's having 2 or more of these features. So we're going to move on to kind of the most meaty part of the talk. And this talk is dense, so please, at the end we can take time for questions. But how about genetics in the metastatic setting? So when the disease is considered, we're going to be trying to contain the disease, it's not going to be available for cure. How do we look at how genetics can be used to guide precision medicine in those treatment choices? A lot of this is evolving, but the genetic information from advanced cancers can inform your standard of care options and certainly expose clinical trial options. It's evolving in the sense of we're getting more information to make better clinical guesses. A lot of this has not been substantiated in the form of a randomized controlled trial. But I'll talk about how I use it and what the evidence behind it is to kind of help me make these standard of care option choices. So in other words, how do I go through with a man whether they should select option A or option B for their metastatic disease? Typically when the cancer is advanced, and I think it's not going to be curative, we're just going to use therapies that are going to prolong survival, but the guy will always have the prostate cancer. In that setting, which is, for example, ones with, for me, I'm a urologist, so I'll see metastatic hormone-sensitive disease the most, I will send off their germline testing to know everything about why the guy got this cancer, and I'll also send somatic testing of the genetics of their tumor to know as much as I can about their tumor itself. And what I found over my last year or so of practice doing this was about 30% have a 3-beta HSD1 allelic variant. I'll talk about that in a second. 10% with a DNA damage repair mutation, 20% with PI3 kinase NP10 alterations, and 4% with MSI, 4% with CDK12 deficiencies. And these can inform my choices about what type of hormonal therapy I want to use for intensification, what type of trials I might want to talk to the patients about, and the use of immunotherapy for prostate cancer. And we'll go through each of these slowly. How do I test for the genetics of their tumor? There's multiple available commercial tests now that look at this. There's the Tempest test, which I prefer, which looks at the tumor RNA, tumor DNA, tumor RNA, and the germline DNA. There's also other tests like Foundation 1 that look at the somatic mutations in the tumor. And what are we learning? So some of this I have to give you a little bit of clinical perspective. I think some of it was covered earlier today. And this is that for metastatic hormone-sensitive prostate cancer, our treatment has evolved. There's now multiple trials, Stampede, Enzamet, Arches, and Titan, that show that you can get cancer survival benefit by intensifying upfront hormonal therapy, like chemical castration, with something like abiraterone, enzalutamide, or apalutamide. Use androgen signaling inhibitors. And so that's sort of becoming or should be the standard for most men. The question is, how do you choose between the apalutamide and enzalutamide that act at the androgen receptor and the Zytiga that acts to prevent production of steroids. And then later on we'll talk about how you choose between that and chemotherapy up front. So you can do it based on toxicities and preferences about the drug itself, but at the genetic level, there are some clues as well. So mostly from work of a scientist named Amos Sharifi at Cleveland Clinic, he looked at androgen metabolism. This is how steroids are made into testosterone-type molecules. And a lot of that happens in the testis, but certainly steroid metabolism to androgens happens in the adrenal glands as well. For extragonadal steroids that are converted to testosterone, there's an enzyme called 3-beta-HSD1 that pushes the pathway towards making testosterone-like precursors that can be used as androgens. If you have a 1245 A to C allelic variant, which is present in a heterozygous way in 45% of the men and homozygous in about 10% of the men, then that gene is more active and more likely to move adrenal precursors to androgen-type molecules. What does that mean? You would say, like, well, Lupron, for example, will affect just the testes and testosterone from the testes. So what will be the effect of having this HSD 3-beta variant? Those guys that are making more adrenal testosterone, they might more quickly progress to metastatic castration-resistant prostate cancer. And in fact, in retrospective studies, that's what they found. And the second question is, okay, so we know we want to intensify their hormonal therapy early, just like shown by these clinical trials, but with which one? So that enzyme, that HSD, 3-beta-HSD1, converts steroid molecules into things that drive prostate cancer, testosterone-type looking things. Abiraterone looks like a steroid. And so abiraterone also gets converted, if you have this allelic variant, into something that is called 3-keto-5-alpha-abiraterone, which can also activate the androgen receptor, and that can be counterproductive. So if I see a man with this 1245C mutation, I will tell them we're going to intensify your therapy, but we're going to use enzalutamide or apalutamide instead of abiraterone, because you'll probably have a better response. And right now there's ongoing clinical trials to sort of prove this in a prospective way. How about for other treatment choices between chemotherapy and androgen signaling inhibition for men with more advanced cancer? This was the PRO-REPAIR-B study, where they looked at people who were progressing to metastatic castration-resistant disease and deciding if they wanted to take docetaxel or take an androgen signaling inhibitor, such as Zytiga or enzalutamide. And what they found is the clinical outcomes for the general population, shown here in the blue and black, were kind of similar, whether they chose to take a taxane, which is docetaxel, or they chose to take an androgen signaling inhibitor as their next step in therapy. But if you were BCR2 mutated, which is in the red, and you chose an androgen signaling inhibitor, like enzalutamide or abiraterone, you did pretty well. But if you chose to do docetaxel as your next step, you did much worse. And so men who have BRCA2 mutations should really be, I think, particularly early in their disease course, staying away from chemotherapy and preferably intensifying their therapy with an abiraterone or enzalutamide. How about making informed decision choices from knowing your mutational status? So not just deciding between available drugs, but looking at things that are actually targeted to your mutation. So again, we'll talk about these DNA damage repair mutations, particularly the BRCA ones. BRCA and other tumor suppressor genes work to maintain genome stability, so they work to keep the DNA together. Cancers will mutate them so that they can then mutate the genome more. But when they do that, the cancers then have to make sure they don't have so many mutations that they get overwhelmed and can't survive at all. And to prevent that kind of a catastrophic genomic instability, they'll upregulate other genes. One of these is PARP, which gets upregulated in BRCA2 mutated patients. PARP can be affected by specific drugs, like PARP inhibitors, both in prostate cancer, breast cancer, and other cancers. They've shown to be efficacious. And recently, the PROfound trial was reported that demonstrated that for patients with BRCA2 mutations, if you had an option between a PARP inhibitor and going the next step of therapy with an androgen signaling axis inhibitor, the PARP inhibitors provided superior cancer outcomes. So again, this is specifically targeting people with mutations in BRCA2. So then going on, say you have a person with advanced disease and they're on therapy and they're developing resistance, and you want to know why they're developing resistance. If you have a new tumor focus that you can biopsy and understand the genetics of that tumor, great. Sometimes you do not have that tumor focus to biopsy, as the prostate cancer patients might be progressing with bone-only disease. And then you can use one of these tests that look at circulating tumor DNA, so DNA shed off the tumor in the bloodstream. And although they're low-frequency events, a few times this last year I've identified people with mutations in the androgen receptor, the testosterone receptor, that will change their treatment choices. So there's mutations in the androgen receptor that can make it so that the steroids can activate the androgen receptor. So if that person is on abiraterone, which is taken with steroids, and they have that mutation found, particularly this L702H mutation, then you may want to change them to enzalutamide. Usually, a change from abiraterone to enzalutamide would not have a good response because that's changing from one androgen targeter to another. But in this case, the reason the tumor is resisting is because it's picked up a mutation that has made it so the thing that you were giving it to kill it is actually activating it. Conversely, with enzalutamide, there are mutations that can cause the androgen receptor to become activated by enzalutamide. And if that's going on, you may want to change to abiraterone as the next therapeutic option. As we understand the tumor biology better, there's been more drugs that can target pathways that are altered in the tumor. And one reason that I'll get full sequencing is that these clinical trials looking at targeting new pathways for prostate cancer have become widely available almost in every area. And so an example of this is that prostate cancer tends to have alterations in the PTEN, PI3 kinase, AKT pathway. Even in our cancer center, which is in North Dallas, not a huge cancer center, we have 2 trials that target specific alterations in that pathway if we see it at the molecular level. And I just picked out one example of some of the alterations. Finally, we'll talk about immunotherapy and genetics. Prostate cancer is thought to be cold, quote unquote, or not very susceptible to immunotherapy. It's not, or I should say, it's not presented itself to the immune system the way that some other cancers like renal cell carcinoma, lung, or melanoma do. There are immune therapies for prostate cancer that work around this, like Provenge, which takes your immune cells and trains them against prostate cancer and gives them back to you. But there's also the recognition that at the genetic level, even though most prostate cancers are cold, some of them, and the number is actually about 2%, will have mutations in their mismatch repair genes, or will have what's called microsatellite instability. Microsatellite instability or mismatch repair deficient cancers tend to make lots of mutations. The more mutations the cancer makes, the more the cancer cell starts not looking like your cell. Normally, our immune system is surveying the body and looking at, like for example, my body, looking at each cell in my body and deciding, is this cell look like Dr. Ross or does it not? If it decides it doesn't, it looks like a cell that might be infected by a virus or like it shouldn't be there, it will attack that cell. Cancers start to mutate, and as they mutate, they start to look different than my normal cells. And my immune system can come by and say, does this look like Dr. Ross or not? And it might say, it doesn't, let's kill it. But lots of times, particularly with prostate cancer that doesn't have a huge mutational burden, it will look enough like me that the cancer cell will not kill the cell, thinking it shouldn't kill anything and cause autoimmunity in me. There are some patients that have mutations in mismatch repair genes that make lots of mutations, and their cancers are exposed more to the immune system. And for those patients, if you turn off that break, that checkpoint in which the cancer is deciding, making a double check that it shouldn't kill one of my cells versus a cell that shouldn't be there, If you turn off that checkpoint with something like anti-PD-1 therapy, there's a common drug is Keytruda, it can actually have an effect on the disease and the immune system will attack that cancer. So Keytruda first was looked at, and other PD-1 inhibitors were looked at in things like melanoma that have high immunogenicity. That's what Jimmy Carter got when he had his brain melanoma. But now there's a recognition that any tumor which has the genetics of microsatellite instability or has MMR deficiency can respond to Keytruda. And there was a blanket approval by the FDA saying that if you've done the genetics on the gentleman and found this, they can get that drug, including patients with metastatic castration-resistant prostate cancer. Albeit to note that only about 2% of the prostate cancer population will have this. They were then looking to see, are there other patients that have prostate cancer that might have a genetic predisposition for making more mutations that might be susceptible to these drugs? And there's some early evidence that people with biallelic CDK12 loss, which is another gene, if they've lost both copies of that gene, it also will cause mutations in something called tandem duplications, allow for the T cells to recognize that cancer cell as foreign more commonly. And if you give therapy against that checkpoint, which is trying to decide is this ROS or not, then that can have an effect on those prostate cancer patients. So we're trying to move that 2% of patients that we can use immunotherapy on to maybe 5% of patients we can use immunotherapy on. So complicated talk, and we'll take some questions in the end. But the issue here is that, and the thing for patients to know and you guys to know, is currently we're able to use very small amount of material, blood, saliva for genetics, small amount of routinely stored tissue from a biopsy for tissue genetics, and we can get a huge amount of molecular information, genome-wide expression profiling, genome-wide next-generation sequencing. And that can help us inform treatment decisions and screening decisions across the disease spectrum. This is of paramount importance, I think, for people with late-stage, kind of like widespread cancers that are incurable, particularly because a lot of the novel therapeutics have been developed to specifically target certain cancer pathways. But it's also important, for example, gene expression and genomics at the level of diagnosis with localized prostate cancers, or for the patients that are trying to make decisions on surveillance or not. So this is that's it for the talk. I'm sure there are some questions. I think we have about 20 minutes. And again, I apologize for the content. It's sort of very dense, but the field has sort of, I don't want to say blown up, but a lot of things that we were working on that I thought were going to come even 20 years later when I was doing my PhD are here now, and that's great. And so, but a lot of clinicians are early in their understanding. A lot of it is heavy stuff. So I appreciate your attention, and please, I'll ask you guys for questions. Yes, sir.
Is there a time period on the specimen that you would need?
Yeah, that's a great question. So even though, so for example, in this scenario, you've had, say, a prostatectomy, and your disease was fine for years, but now 5 years later, the disease recurs and you want to know what's going on. Most of the companies say that their time limit is around 5 years. They tend not to process stuff before that. When I was doing genetics and genomics in the lab, I found that the break point is actually a little bit post 10 years in terms of when you can really get good material out of the things. Because of that, again, the companies see that because they see some failures, and when the test fails, they just eat the cost because they can't charge anyone. So they put that hard line at 5 years, and for that reason, I tend to within